Okay, let us go to the next speaker. He is Sarita Rao, Dr. Sarita Rao. Now let us start from our Bangladeshi speaker, Dr. Kaisar Nasrullah Khan, and he will be speaking on how IVAS changed my PCI strategy, and he will show some interesting cases as well.
Thank you, good friend Khalek, one of the most academician and good person. Assalamu alaikum and good afternoon to you all. I hope all the guest speaker has gone to room for taking nap. They will come back soon. So I'm giving my talk first, how IVAS changed my PCI practice. Interesting cases. Nothing to disclose. When you drive a car in rainy days, you can't see further in your front glass. But if you use wiper on the glass, everything becomes clear to bring confidence in you for a safe drive. Similarly, IVAS OCT gives you a clear vision in your intervention plan like the wiper. The use of imaging in coronary intervention, mainly basically for three reasons. IVAS in pre-intervention, IVAS in post-intervention after putting the stent, and IVAS in some special circumstances. I will give three example cases for these three reasons. Why we use IVAS. For pre-intervention, we see severity of stenosis, nature of lesion, need for plaque modification, and size of balloon and stent size. For post-intervention, after putting the stent, we see stent expansion. It is the most important MSA marker for future long-term outcome, malapposition, tissue prolapse, thrombus, edge dissection. So question one, what is the IVAS predictor of ISR stent failure in the future? A, stent expansion, B, stent apposition, C, edge dissection, D, all of above. So if you see one thing after post-stenting, we should see stent expansion because it correlates with future stent failure or ISR. And this is a very important picture, what we should look for after post-stent assessment by IVAS. And some special circumstances we use IVAS, like IVAS in left main, IVAS in bifurcation lesion, IVAS in CTO to see the where in the false tract or true lumen. And IVAS guided PCI is better than angio guided PCI in all registries and trials, and it reduced target vessel failure by 47%. So case one, when we use IVAS in pre-intervention. This is the example of using IVAS and making decision in pre-intervention. A 75 years old person, TVD left main disease, EF normal, LED showed 80% proximal stenosis with some calcification. So I am not sure whether I will do with balloon or atherectomy or plaque modification. For this decision, I need to do IVAS. So when I did IVAS, I saw there is 270-degree more calcium arc, more than 5 millimeter in length. So that seeing this picture by IVAS helped me to take decision for taking upfront rotablation with 180,000 RPM. If I would not have used IVAS, I would try it with balloon and then cutting balloon, etc. This reduces my procedure time and also my complications. So after IVAS, again I saw whether it is well ablated or not. There are two cracks in the opposite side of the calcium ring. So now the stent will expand. And now this is the final shot, you can see, and also the post-stent IVAS. And MLA was very good, 13 in left main, and proximal LED was 7.84. Now, the second case is for IVAS in post-intervention. So when we use IVUS in post-intervention, how it helped us. Mr. X, 62 years old, came with CCS class 3 angina, cabbage, history with 3 grafts, Lima LED, RSVT, OM, distal RCA. You can see is a LED is blocked after mid, RCA is 100% occluded from ostium, RCA graft is patent. OM graft has got disease, 70% distal. Lima is patent. But this is a huge LED territory and SARC territory. LED 90% and mid LED is 100%, and it is not getting retrograde supply from Lima. So this area is ischemic and big diagonal, huge territory, and also a big septal, which is ischemic. That's why patient is having pain. Even the Lima to LED is patent. So though proximal to Lima graft, there is no retrograde supply. LED is blocked. And also there is severe ostial SARC disease with no retrograde flow from OM graft. So this is a huge territory which is ischemic for class 3 angina. Even the Lima to LED is patent. So our RSVT to OM graft is disease. So we planned for decay crush for left main to LED and SARC for this huge territory, and did IVUS in predilation. And you can see the SARC ostium is calcified, but not more than 180 degree, and also fibrotic lesion is there. So from that interpretation, we did cutting balloon of the SARC ostium, and then did the decay crush. And result was satisfactory. But when I did IVUS, the SARC ostium showed the MSA is 4.1. Otherwise, with this picture, I was so happy, I would have left like this. But when I did IVUS in post-intervention, I see the SARC ostium is not well expanded. It is only 4.1. Now my next question, what is the MSA of SARC ostium we should be happy with for future good long-term outcome? 4, 5, 6, or 7? For Asian population, if it is proximal left main, it is 8, SARC ostium 5, LED ostium 6, and the confluence space is 7. But my SARC ostium was 4.1. So I again took a bigger balloon and then did kissing balloon, and now I can see the SARC ostium is 5.43. So though there is some calcium, so the stent is expanded elliptically, but MSA is satisfactory, more than 5. So I'm happy. This is the example of IVUS in post-intervention. Now IVUS in special circumstances. A 62 years old lady came with AMI inferior, so echo showed EF 70%. There is a 90% stenosis in the mid RCA, straightforward case, but unfortunately, just when we were about to start the procedure, we found a catheter-induced dissection at the RC ostium, which was gradually progressing. The fellow gave dye, so it extended. So we are fighting almost 30 minutes to find the true track, even with 2 wires, but unfortunately extending the dissection. So I took the guide catheter out in the aorta, took a shot to find the true track below, and pass a slippery wire, filter XTR wire, to get the true track. And then the lesion was crossed with great difficulty and dilated. We can see dissection was extending with dye injection, so a long stent was taken and the whole length of it was covered. But just as the stent is inflated, we can see something is extending distally. You can see the arrow. When I put the stent, something extended distally. So after putting the stent, everything looks fine, but there is some haziness at the distal end of the stent. So what is it? Is it dissection, thrombus, or something else? So we went for IVUS. And IVUS showed this at the distal end, edge of the stent. You can see the black portion in the media, like a crescentic like a moon. So my question to the fellows, question 3, what this haziness distal to the stent could be? Is it edge dissection, is thrombus, it is intramural hematoma, or all of above? So with angio, I was confused. It might be edge dissection, it might be thrombus, it might be hematoma. But when I did IVUS, I was confident it is an intramural hematoma. And it was compressing almost 50% of the vessel lumen. Ideal thing should be, I should take a cutting balloon and cut the vessel wall so that the blood drains into the true lumen, because vessel wall was normal. But unfortunately, at that time, I did not have any cutting balloon. So I tried to puncture the hematoma with a CTO wire, I think Conquest Pro 9, but I failed. So I was afraid if I place second stent there, the hematoma will extend distally and close my PD and PLV. So at that time, I took a second stent distal to the hematoma, placed it into the normal artery, and then I sealed the hematoma in between these two stents with a third stent. That was whatever came to my mind. So an interventional cardiologist have to be innovative. You can't have all the things by book. Sometimes you don't have the hardware, or sometimes the time is not suitable for you. So I thought that at that moment, that's the way to treat this intramural hematoma. And this is the final angiogram. You can see, and also I did the IVUS. It is well sealed, and with pressure, the blood came out into the lumen. So take home message, compared with angiography, the use of IVUS guided PCI reduces the risk of cardiovascular death, MI, TLR, and MACE. Regarding high-risk patients and complex lesion, example left main, CTO, severe calcium, IVUS imaging is most beneficial to evaluate the lesion, predict the treatment efficacy, reveal the complication, and optimate the procedure result. So I give 3 cases as a 3 example when we are benefited by using IVUS. Case number 1 with pre-intervention, case number 2 post-intervention, and case number 3 is in special case.